and it's had a powerful effect on me and my world and my priorities. And he closes, I wish that the final chapter in all of your stories can be one in which you are given the gift of some time to live with your fatal illness. Mortality will teach us a lot about life if we let it. My suggestion is that we simply let it and listen closely. In realizing that these times of life are first inevitable, and secondly, fundamentally personal, not fundamentally medical, we can better advocate for ourselves and those we love in the medical aspects without forgetting the personal, deriving some benefit to ourselves and those we leave behind during these difficult but normal times of life of illness, caregiving, dying, and grieving. In the work that I have done over the years, we've built a specialty now called palliative care, building out from the hospice base without that restriction of having to be dying to get it. And palliative care programs are now spreading throughout the country. There are ones in virtually all of the large hospitals in LA, though few of them are robust. There's some consumer demand needed. And in fact, I would say that collectively, all of us need to be savvy consumers individually so that we and those we love get the best care we possibly can, demand shared decision-making, demand second and third and fourth opinions when necessary, just making sure that one of those opinions is with a palliative care team. But collectively, also, we need to transform these health systems. Money is not the object. We can give better care with less money if we actually provide care that is aligned with what matters most to people, and not just the most treatment possible, but the best care possible. I long say when I speak in an advocacy frame nationally, I often say to my colleagues in palliative care, we're standing on a two-legged stool in trying to transform healthcare. Right? We've proven that much better care is possible, much higher quality, and we can deliver that at significantly lower costs. But the third leg of the stool is consumer demand. So far, people don't know about us, and if they do know about it, they don't want to talk about any of it, right? Which doesn't make for an empowered consumer movement. The more savvy we are, the more assertive we are, the more you will see the healthcare system flex and adapt and meet your higher expectations. That's why it's such a pleasure to be among leaders in this great city that I really and truly love. So thank you for having me, and thank you for allowing me to share my thoughts today.
That was so moving and inspirational. It's now our Q&A time. So if you have a question for Dr. Byock, will you raise your hand, and Morgan will bring you the microphone. Would you just introduce yourself briefly and where you're from?
Michael.
Jim Thomas. I'm from Town Hall. I'm curious to get your thoughts about hospice versus home care in this sense. To me, I haven't thought a lot about it, but to the extent I have, it seems to me that it's a little cold to go off to a hospice as opposed to staying at home during your last moment. I'd like thoughts about that.
So in the United States, hospice is home care. I think what you're implying is that hospice is a place, as a facility, and there are hospice facilities. In fact, there are too few of them, because some people are well served in a facility, but it's a small fraction of people served by hospice programs. Hospice is a home care program for people who are seriously ill and acknowledge that they are dying. I often say that the difference between hospice and routine home care is like, hospice is like home care on steroids, right? There's a physician who's directly involved. They're available 24 hours a day. They will come to you at any hour of the day or night if your pain gets out of control, or you're having severe anxiety, or your family is having some urgent problem. They're always available on the other end of the phone, and they know who you are. Home care is a pretty restricted set of services under Medicare. You have to be homebound, and it has to be medically necessary. Those two restrictions go away with hospice care. So I think it's simply a number of people have this belief that hospice is a place, and I understand that, but it's actually more a home care service.
So do you have to sign up for hospice?
You have to sign up. Yeah. So the problem with hospice is you have to be dying to get it. Right? It's a brilliant set of services that for your comfort, your quality of life, your nutrition, your pain control, your sleeping, your activities, your bowels, all that stuff, and your family's well-being. You're there supporting them in caregiving. But under Medicare, Congress decided that you have to be dying to get it, and you have to acknowledge you're dying, something that many of my patients are not about to do. And you have to give up treatment for your cancer or your heart failure or whatever it is in order to get that big package of services, very generous package of services that hospice represents. So yes, you do have to sign up for it. You have to be eligible for it and sign up for it. And interestingly, what drives me crazy about this is those restrictions could be loosened and we still save money. In fact, studies have now shown that concurrent treatment for cancer, for instance, and hospice care actually saves Medicare money. So we actually have a system, the routine system, provides lower quality at higher costs. I know that sounds odd, but that's verifiably true. Oh, thank you. Yes.
I have one question about hospice care. Said that in my case, my daughter's the only relative I have around. Now, if I were to be at home in hospice care, that would be just too much for her and too much burden on one person.
So you're right that caregiving is often a team sport. No question about it. Hospice is fairly brilliant at supporting family caregivers and wrapping around them an array of services and support to lessen the heaviness of the burden of caregiving, including some volunteer support to at least allow the primary caregiver to get away during the day for an hour or two to go to their own medical appointments or just the things that they need, including get some sunshine and exercise and all of that. But often, depending on the needs of the person who's ill, it is too much for one person. And so there are other models out there that can help. I said it takes a community. Now there are intentional communities these days that are forming, several of them in LA, around the needs of seriously ill people or frail elders. There's the village model. There's a couple of villages. I'm connected with the Palos Verdes village, which is a kind of partly a bartering model where people get together and they barter services. So a retired plumber may barter some of his time in exchange for some bartered tax, or accounting time, that sort of thing. There are other intentional communities. The Cato people are here. You're one, where Cato in the Japanese American community is forming to help people age in place if possible and thrive in place, providing services to them, doing the group buying and the careful assessments that you think of like with Angie's List, doing this as a community. And in Cato's and others communities model, being culturally sensitive to the food preferences and the traditions and the like of the people they serve. So there's some of that being developed to help individual caregivers. And then most hospice programs have some access to a residential facility, a hospice of the sort you were mentioning, when if symptoms got out of control or it was the burden was too much for a single caregiver. We got a long way to go, though.
Thank you, Dr. Byock.
You're welcome.
It's a pleasure to hear you. I actually have a company called Compassionate Senior Solutions.
Thank you.
I place seniors in senior living, work with the families. My name is Sandra Heller. One thing I think, is important, and you've shared so much valuable information, and that is everyone gets to choose their own hospice company. That don't be fooled by doctors. It's a big business now.
Yes.
So there's thousands of companies that have put out a shingle saying, I'm a hospice company. It's important to do the research, and I just thought maybe if you could address a little bit more about that, because I think it is important.
Sure. So I really appreciate the comment because, when we started, I was here at kind of the dawn of the hospice movement in the United States. I'm that old. And it was a social movement. I mean, we didn't have a reimbursement stream until '81 when the Medicare benefit came along. And it was all mission. And now it's become an industry. And the largest segment of providers of hospice care in America now by far is the for-profits. I, by the way, don't have a problem with for-profit hospice. I know some for-profit hospice companies that are superb, but everyone that I know that falls into that superb category is wholly owned by a person or a family. I do have a problem with the hospice programs that have gone through an IPO and are now traded on Wall Street. They have stockholders that they have to satisfy. And I have seen over the years, I've known of programs that were wholly owned, were superb. They went through an IPO, they became, investor owned, and qualities quickly diminished. So I actually, when I am in a situation where I'm not bound by Medicare regulations that make it illegal to steer people in one way or another, even though in this great county that's happening absolutely every day by doctors who have stake in the companies that they are directing patients to. Don't get me started. It's absolutely appalling, but it's happening frequently. But I do have a preference for nonprofit hospices, which by data perform better than most nonprofits, for-profits. And if you're looking for a for-profit, make sure you know who owns it and that they're a member of this community. One of the things that I say is when you ultimately, I give a whole sort of talk about how to work with doctors in a health system if you or someone you love is seriously ill. One thing to remember is you can always fire doctors and hospice programs. If they're not meeting your needs, this is about you, this isn't about them. Don't feel badly about hurting their feelings. They'll get over it, they'll mend. Get the care that you or your mother or father need. And if you have to change programs because they're not there answering the call at night or they're too heavy-handed, just do so. Doctors who won't listen to you, time to change. Might be a nice person, might be a great doc. I want somebody who can listen, who actually cares.
Thank you very much, Dr. Byock, for your ideas. I'm sure you have a couple of opinions. I'm very proud of the fact that we have a law that healthcare providers actually need to relieve suffering. So it's the law, and you have to take care of the fact that they need suffering as well. We also are having a big discussion on euthanasia. We all know that euthanasia can never be a replacement for good hospice care. That's the main thing, but I'd love to hear your thoughts from that, the matter of euthanasia.
So I've been part of this debate for over 30 years, maybe 35 years, and I've always been on the con side of the legalization of assisted suicide. The pro side would object to you using the word euthanasia. However, you're not far from true. But in California these days, the best thing I can say about the law being passed is it's now law and we don't have to debate it. But I would point out that since passing the law and Jerry Brown signing the law, we have not improved medical education an iota. We have not improved the standards for what you can call a palliative care program in our acute care hospitals a bit, and most of them are insufficient. We have not improved staffing in our nursing homes a tiny bit, and I can't tell you how many people have told me, Doc, shoot me before you send me to one of those places, right? So since we passed the law, the proponents of assisted suicide who keep talking about this as being the last resort they've gone away. They've gone to Connecticut or to other places to pass other laws. but we're still stuck living in a place where we're not training our doctors sufficiently, we're not staffing our palliative care programs, we're not staffing our nursing homes, and where the conditions that make people feel like their life is not worth living haven't changed a bit. And yet all of those are fixable problems. These are all man-made problems. They're not baked into the human condition. I would also point out that in his recent budget, Jerry Brown, Governor Brown, who I voted for several times, I have to tell you. I seem to only live in California when he's governor somehow. He has $2.3 million in the budget to pay for lethal medications under the End-of-Life Options Act, and he has just delayed for yet another year the funding of SB 1004, passed in the fall of 2014, that would have funded concurrent palliative care for Medicaid recipients. Now, if you're a Medicaid recipient with bad cancer or liver failure, what's the message there? You know, this is the slippery slope that people who have debated me for years have said, oh, Dr. Byock, you're exaggerating, it'll never, ever, ever, ever happen. Okay, but I think this is it. I'm sort of feeling myself going down that slope. Yeah. That's my thoughts.
Thank you, Dr. Byock. I'm Dr. Mitchell at the Cancer Support Community. Kind of our name says some parts of the talk you're giving speaks to that idea of support. Just one comment and then one question. Just a comment about in the world of psychosocial support and hospice care, we learn from lung cancer research that those who participated in hospice actually live longer, live better quality of life at lower cost. So my question is, again, to the third leg of that stool, is there a way of changing the language around palliative care and hospice so that we in the world at large could access it in a meaningful way? We have the same problem in psychosocial support for people with cancer. The word is a mouthful. Perhaps you...
So I'll give you a couple of answers to that. Yes, a lot of places are calling it supportive care and renaming their palliative care program supportive care, which seems to be better. But you actually have to change the meaning more than the name. If palliative care means, if you can't get into a palliative care program at, X university hospital unless you're dying, then people are going to know that, patients are going to know that, their referring physicians are going to know that, and you won't be able to say palliative care anywhere. Don't say, when you can go in and see the patient, but don't say palliative care, right? You could call it the Rainbow Program, but if it really is wink, wink for people who are dying, within 2 years, you won't be able to say rainbow in the room, right? Because it's going to mean dying, right? We have to change the meaning. It has to become the best care possible for you is your cancer treatment along with palliative care or supportive care, right? I mean, you folks, I often say this, multiple people have said this from cancer centers to me, that you've got to change the name because people are worried about the word palliative care. I said, well, you got to change that name on your building because people are scared about the word cancer. So you should change this to the Little Funny Bump Center, because people are getting the wrong, right? It matters the connotation we put to it. Now, I spent a decade at Dartmouth running the palliative care program there, and I heard so many colleagues say this when I first came. And palliative care had just become a formal medical subspecialty, so we were pretty proud of the name, and we resisted changing the name, but we changed the meaning. And within 3 years, at Dartmouth, palliative care did not mean you were dying. It meant you deserved an extra layer of support from this specialty team to take care of your symptoms, your emotional well-being, your coordinate your service, crisis management plans, family support. And after a while, within that environment, it had no sting whatsoever. It was a positive. So yes and yes. Got to maybe change the name, got to change the meaning.
This is Kathy Richards.
Hi.
I think you may have somewhat answered it, but maybe kind of short. So what is the difference between palliative care and hospice?
So hospice care is a program funded by Medicare that is a team-based approach to your comfort and quality of life, your family support, right? That does all of these services in the home. It's well funded, but you got to be dying to get it under Medicare. Palliative care is a very similar program, less robustly built out in many of our organizations, but a very similar program, doesn't have that same Medicare funding, but doesn't also require you to give up anything to get it. So you can get both treatment for your disease and palliative care before you're willing or ready for hospice care.
So you don't have to be done.
You do not have to be dying to get it. Hi, Carl.
My name is Carl Dickerson, doctor, as we've spoken earlier. You know, I can predict one's life expectancy based on statistics, based on the zip code where they live. Now, with that type of actuarial analysis and accumulated documentation and statistics, why not require every new hospital that's being built to have a wing dedicated exclusively to end-of-life care? It would seem to me that it could be statistically estimated how many beds should be set aside for that per community that that hospital is serving. Now that way, it becomes more equal. The equality is there for all levels of income.
I love the way you're thinking. I would say that thinking about beds is kind of a 20th century model. Think about caring capacity. Most people will rather not be in an institution. You will need some of those beds, but we're trying to do similar things within the Providence Health and Services system about caring capacity. The how many teams and how large must those teams be to take good care of people during serious illness and through the end of their life and support their families. Yes, some of those people will need specialty beds, but more of them will just need help staying at home so they don't have to come through the ER and don't have to be cared for in an institution. Does that make sense, or you're looking at me?
Yeah, well, it makes sense. However, everyone doesn't fit into that stovepipe. There are people that even if they wanted to have care at home,
Need a bed.
Right.
I agree with you.
Right.
I agree with you. But that's probably less than 20% of people. Most people today can be cared for in non-facility settings. If there's plenty of staff, if there's those home care and hospice teams available.
Last question here.
Hi, Emily.
Hi, it was such a pleasure to speak with you as a private for the presentation today. Thank you so much for your time and being
Sure.
so generous with your information. I introduce myself as a gerontologist and musician. I'm currently an independent agent, but my training and academic professorship was affiliated with the University of Southern California. I was curious to your thoughts related to the arts and humanities as palliative and therapeutic dimensional opportunities for end of life.
Sure.
And your thoughts, and if you've seen efficacy or any kind of transformative, constructive opportunities.
So when you think about illness and dying as fundamentally personal, you realize how important the arts and music can be. The way to improve the quality of people's lives often involves engaging them in things that they love, things that give them pleasure. Arts, music, children. I often say, put a toddler in a isolated, frail elder's arms, and the reaction it provokes, if it happened because of a drug, would be labeled caution, maybe habit forming. The people light up, right? Music, the best example I can give you, and I encourage you to write this one down. If you haven't seen it, watch the movie Alive Inside. Alive Inside. It's available from Netflix. You can see 8 and 10 minute segments of it on YouTube. Here, they have taken music as a therapeutic intervention into dementia care facilities with some of people with pretty advanced dementia. Isolated, depressed, withdrawn, no quality of life. We think they're hopeless. You should just see what happens when they put on music that these people love. It's like a reawakening. So don't tell me that these people are hopeless. We have just been assuming that they're hopeless and giving up on them. Pets will do it, dogs, little puppies. You should see if you can elicit joy in somebody, I would suggest that that joy is tantamount to some degree of capacity for well-being that resides within them. So I think that the work that you're talking about and the use of the arts and humanities is an untapped resource that may help us rediscover some latent joy and well-being within the human condition. Thank you all so very much. It's been a pleasure. Thank you very much.
Thank you, Dr. Byock. This concludes our program at Town Hall, but we hope to see you at a future program, so sign up now. Thank you so